Good evening, and thank you for being here. My name is Sarah Osman, and over the past several weeks, I've had the opportunity to work with Tri-Cities Community Health on a project aimed at understanding and addressing colorectal cancer screening gaps. Today, I'll walk you through what I learned, what I created, and how this experience strengthened my practice as a public health professional. I'll start with a brief overview of the purpose and setting of my applied practice experience. The purpose of my applied practice experience was to identify screening disparities and develop strategies that make preventative care more accessible and culturally responsive. Tri Cities Community Health is a federally qualified health center. They play a critical role in serving populations that often face barriers to preventive care. With guidance from my site supervisor and support from community health workers, I analyzed screening trends and community needs to understand where the most significant gaps existed. My role as an intern involved translating evidence based approaches into practical tools for the clinic, as well as conducting electronic health records analysis, reviewing workflows, developing culturally responsive educational material, and designing an improvement plan that aligned with Tri Cities Community Health Clinic operational capacity. I completed three major work products that directly supported Tri Cities Community Health goals. The EHR analysis highlighted where disparities existed and who was most effective. The improvement brief translated those findings into actionable strategies tailored to the clinic's capacity. I also created educational materials to make screening information more accessible and culturally relevant. As you guys can see on the screen right now, the activities for this project were developed through a structured process grounded in national colorectal cancer screening guidelines and Tri-Cities Community Health organizational priorities. I began with I began by meeting with my site supervisor to clarify goals, available resources, and expectations, which informed the design of my analysis plan and workflow assessment. Implementation involved systematically extracting and cleaning EHR data, engaging community health workers to understand patient level and cultural barriers, and continuously refining materials and recommendation based on my supervisor's feedback. As the work progressed, activities were modified to address missing data fields, incorporate some of the community health workers' insights, and most importantly, to ensure cultural and linguistic relevance. Across approximately 100 to 120 hours, these activities were evaluated for accuracy, feasibility, and alignment with evidence based best practices. These five competencies reflect how I applied core Masters of Public Health skills through the applied practice experience. For competency one, I relied on the National Colorectal Cancer Roundtable and the U.S. Preventative Services Task Force guidance to ensure that all recommendations, especially around the fit kits used and structural barriers, were grounded in current up to date evidence. For competence 4, for competency 4 and 7, they were both demonstrated through my work with EHR data and community health workers' insights to identify where screening gaps existed and what real-world factors contributed to them. For competency 9, I designed a population-level improvement plan that directly addressed the disparities identified in the EHR analysis. The plan integ- the plan integrated evidence-based strategies with community health workers' insights to ensure culturally relevant and feasibility within the clinic's existing workflows. By developing a clear logic model, I was able to connect inputs, activities, and outcomes to create a practical roadmap for implementation and future evaluation. And for the final competency, Competency 19 was reflected in the dashboards, briefs, and patient facing material I created to communicate findings. The data revealed a consistent disparity between male and female patients, with men showing significantly lower screening completion. Community health workers' insights revealed that many men avoid screening because they don't feel symptomatic, are uncomfortable discussing GI health, and experience stigma or fear of others knowing that they are being screened, which adds an important cultural and behavioral context to these numbers. These findings helped shape recommendations and patient facing materials tailored specifically to male patients' concerns. The analysis also revealed that male patients aged 45 to 54 had the lowest screening completion, which is important because this age group was recently added to the US Preventative Service Task Force screening guidelines. Many patients are still unaware that screening now begins at age 45, and community health workers noted that this group often doesn't see themselves as at risk yet. These findings support the need for earlier education and male focused outreach, especially as this age group represents a critical window for prevention. This disparity also reinforces why guideline changes must be paired with proactive communication strategies. Among male patients, notable disparities appeared across racial groups and ethnic groups, with Hispanic, Latino, and Black men having lower screening completion. Community health workers emphasized that language barriers, cultural norms, and historical mistrust of the health system all influence willingness to participate in screening. These findings show that addressing disparities requires more than providing information. It requires tailored communication and outreach strategies that resonate with each community. Insurance status played a significant role in screening participation, with Medicaid and self pay patients having the lowest completion rates. Community health workers shared that cost uncertainty, fear of medical bills, and limited coverage often, dis- often discouraged male patients from pursuing colorectal cancer screening. These disparities show that improving access requires not only education but also clear communication about cost, support for financial navigation, and expanded low barrier options. This applied practice experience allowed me to integrate clinical data with community insight to understand colorectal cancer screening disparities at Tri Cities Community Health. By combining electronic health records analysis with community health workers' insights, I was able to understand not just where gaps existed, but why they persist, particularly among male patients and underserved groups. Developing the improvement plan and educational materials reinforced the importance of culturally tailored and communication, as well as feasible systematical based strategies. Overall, this experience strengthened my analytical and program design skills and deepened my commitment to advancing equity within my community. Thank you for listening. I'm excited to carry the lessons from this project forward as I continue developing as a public health professional. Thank you.